Singapore plans to ramp up COVID-19 vaccinations with more centres and mobile units delivering over 70,000 shots daily. From the English variant to the South African strain, how worried should you be about the effect of new mutations? We'll hear from two local experts. And ending on a low note, US President Donald Trump will leave the White House with his worst ever approval ratings. It's 5:30 p.m. here in Singapore. You're watching The Big Story, coming to you live from the Straits Times newsroom. I'm Haryanto Diman. Now you can subscribe to the Straits Times channel so you never miss a single episode. Well, news just in: pilots for the nightlife sector to allow the reopening of some nightlife outlets like nightclubs and karaoke outlets will be deferred until further notice. According to the Ministries of Home Affairs and Trade and Industry, this is to further prevent community transmission and clusters forming in high-risk settings in light of the rising number of community cases recently. But the pilot for bars and pubs, which commenced earlier, will continue for now. 30 new COVID-19 cases were confirmed today. 26 of them were imported and placed on stay-home notices on arrival in Singapore. Today's count also included 4 cases in the community. In a Facebook post last night, COVID-19 Task Force co-chair Lawrence Wong said that additional measures may be needed as community cases inch up and a local cluster has emerged for the first time in several months. Meanwhile, from next month, Singapore is looking to potentially deliver over 70,000 COVID-19 shots a day. According to tender documents seen by the Straits Times, the Health Ministry wants to appoint a vendor to set up 36 vaccination centres. Each centre should be able to cater to at least 2,000 people a day and could be established in vacant schools, community clubs and sports halls. The vendor will also set up 10 roving teams to provide mass vaccinations for places like nursing homes. Appointed vendors will also have to make sure that vaccines are stored and handled properly and that supply is sufficient. As Singapore and countries around the world strive to manage the virus, now with vaccines made available, the emergence of a new strain last month has raised concerns, possibly posing another obstacle in the fight against the pandemic. The new virus strain was said to be more infectious and transmissible, and experts the Straits Times spoke to are divided on the effect that new strains pose in the fight against the pandemic. Some feel that what's more important is not whether a virus mutation spreads more easily, but the measures in place to stop any spread. While to others, the worry is that the more transmissible variant could potentially overcome our current safe management measures and lead to renewed epidemic growth. To discuss this further are two of these experts. We have Professor Dale Fisher, a senior infectious diseases consultant from National University Hospital, as well as Associate Professor Alex Cook, Vice Dean of Research at NUS's Swee Hock School of Public Health. Welcome, professors. Prof. Cook, let's start with you. When the new strain is described as more infectious and able to spread more easily, how do we measure this? How much more infectious are the new variants?
So we measure the infectiousness of a virus through its reproduction number. This represents how many people will be infected by a single index case. We don't know exactly what it is in the absence of control for COVID because we've always been trying to control it, but we suspect it's probably somewhere around about 2 to 2.5 in general. So the new variants of the virus which have been identified, for example, in England and South Africa, the suggestion seems to be from epidemiological data that they are more transmissible. The reproduction number would be higher than it would be for the wild type virus. And if that is the case, then we were thinking that the reproduction number is probably around about 50% higher. So the virus is 50% more transmissible than the existing virus that we've been used to for the last year.
Right. Now over to you, Prof. Fisher. Other than being more contagious, is there anything else that's worrying about these new strains? And perhaps you can put it into context for us in relation to other epidemics like SARS and the Spanish flu.
Yeah, thanks, Haryanto. It's good to be back on The Big Story again. Firstly, if I could just add on to Alex's comment. When I first heard that there were claims it was more contagious, I automatically felt that it was probably just because of poor control measures or difficulty implementing all the control measures. But Public Health England actually did a nice case-controlled study where they looked at people that had the variant. They looked at people that also had COVID but not the variant. They looked at all their close contacts, and it was 15% of the close contacts of the new variant became positive, but less than 10% of people with previous variants became positive. So it's a very real thing. And to move on to your question, Haryanto, I think what this tells us is that that coronaviruses don't actually mutate very much in sort of overall view of viruses, but we have now around 500,000 new cases every day. So that's probably about 5 million active cases in the world at any one time. And if each of these is mutating maybe just once every 2 weeks or something like that, then you can see how the number of different variants can really explode. Now, and as indeed they have, we've got obviously many thousands of different gene sequences now. So mutations can go any of several ways, and as the vast majority obviously don't make any difference to the virus's activity at all. But what we're seeing here is that because of a different nucleic acid, which means a different amino acid in the protein, it changes the look of the spike protein a little bit. And that's what's made it more transmissible. But future variations could show that it's less transmissible or more virulent or less virulent. Certainly in the Spanish flu, the second wave was certainly more virulent than the first one, but flu's obviously even more mutagenic. So I think that's it really just introduces a lot of unknowns, actually, and another reason to bring these numbers down under control.
Right. Prof, I just want to pick up on what you said earlier as well. Now, it seems unclear if it's just that the variant is much more contagious, or for instance, like you said, that the lack of safety measures like safe distancing and mask wearing is contributing to the transmission in other countries. So how much of a concern is this variant for us in Singapore? Because Prof. Fisher, you've told ST before that, just to quote you, the infection prevention interventions work irrespective of the infectiousness. Can you elaborate on that?
Yeah, I think that same article probably said, but it's going to be less forgiving. So if it's more infectious, then that means a smaller dose, a smaller inoculum can cause disease. Maybe you're being exposed to a positive case. You don't have to be exposed for as long. Maybe it's more likely you can pick it up on your hands or infect yourself. But the point I wanted to make was all the things that we know to do well, all the things that we need to do, they remain. It's still mostly droplets. It can be airborne under some circumstances, contact with contaminated surfaces. Well, the bottom line is we just have to be a lot more vigilant. Nothing has actually changed. It's just that if you slip up, then there's a higher likelihood of infection spreading. Right.
Prof. Cook, your thoughts on this, because you believe that there is a cause for worry.
Yes, so I mean, I agree with what Dale says. Why am I worried about the virus is, so, ever since we first went into phase 2, we've been able to keep the reproduction number to at or below 1 in Singapore. So for every case, they've only generated at most 1 extra case on average. So we're able to keep things under control. We don't know exactly how much below 1 it has been. And now that we moved into phase 3, we're not completely sure whether the reproduction number is kept to below 1 or whether it's at 1 or a little bit above it. But if the evidence from England were to extrapolate to Singapore, if the virus were to become established here, then that would suggest that the reproduction number would go up by a factor of about 0.5. So if the reproduction number is now 1, it would go up to 1.5. As Dale says, the same interventions that we're currently doing, we need to keep on doing them, but they may become less effective. So if the reproduction number has gone up to 1.5, it means that we're moving back into a period where there would be exponential growth, probably at a low level, but still exponential growth. And that would be a cause for concern. It would mean that we may end up with the death rate rising again. We may end up with more people going to ICU, and it would effectively becoming a kind of like a race between a new variant virus, if it became established here, against the ability of us to deploy the vaccine en masse at speed.
Right, and on the vaccine, like you mentioned, Prof. Cook, perhaps it's worth reiterating, will the vaccines work against the variants?
So I think the scientific consensus just now is that we think it will, but we think it will. We're not completely sure. And I think a lot of the studies which are ongoing just now in places where the variants have been established already are trying to determine whether the vaccines are still as efficacious or whether there's a bit of a decline in efficacy compared to the older variant. It's not something that's new. I mean, we see this for flu, for example. Every year we consider whether we need to update the formulation for the flu vaccines. So flu, as Dale says, is a very mutagenic. So it mutates much more than what we think the SARS-CoV-2 virus does. But in principle, we may need to adapt the makeup of the vaccines over time if it turns out that the efficacy starts to decay as the new variants become more widespread.
Right. Prof. Fisher, your thoughts, would you like to weigh in?
Yeah, of course, and Alex makes some perfect points there. I agree that it'll take more drastic changes than what we've seen from the current variants, but if we start to see that there's vaccine escape and that this vaccine doesn't cover this variant and this variant does become established in our region, then that would be a cause to modify the vaccine or else combine it so that there's 2 or 3 strains or 4 strains are covered in the one vaccine. We're not seeing that as necessary yet. And I don't believe we will see it as necessary if we can get numbers down. But as I said earlier, with 5 million active cases in the world, we're going to see a lot more variants, and what their effect will be, we don't know. But I agree with Alex that the vaccines still currently work, and there's an expectation that'll continue to be so until there's major changes in the variations.
Right. Well, thank you so much, professors, but we want you to stay on the line because we want to hear your thoughts on reports out of Norway of a recent string of deaths among the elderly there after they were vaccinated against COVID-19. Now, Norwegian health authorities are saying there is no evidence of a direct link between the recent deaths among elderly people inoculated against COVID-19 and the vaccine they received. 33 people in the country, 75 years old and above, have died following immunization. The Norwegian Medicines Agency noted all of them were already seriously ill and said, quote, "It's difficult to prove that it's the vaccine which is the direct cause." But the agency also said that it's possible that the side effects of immunization can, in some cases, tip the patients into a more serious cause of the underlying disease. Until last Friday, Norway had only used the Pfizer-BioNTech vaccine. The companies are now working with Norway to look into the deaths. Now let's bring in our experts once again. Prof. Fisher, should the elderly in Singapore be concerned over getting their vaccine? Now, in light of what we're seeing in Norway, Germany as well.
So firstly, we need to look at what's happened in Europe and assess the validity. I read that there are 400 nursing home deaths every week in Norway. So that's not to trivialize those, but you're injecting a part of the community with a high death rate anyway. So I think this does need to be kept in perspective. I do accept what they're saying, that it's, I think they mentioned fever, nausea, diarrhea. as side effects. And if for instance, an elderly person is very frail and perhaps has some renal failure or cardiac failure, or and then gets further dehydrated through diarrhea, then that could have consequences if someone is very frail, and that's the message Norway's giving out, and they're investigating it. I think the important message here is, though, that even though the phase 3 trials are complete and we're rolling out vaccinations now, and now there's been tens of millions of people around the world had it, this post-marketing surveillance needs to continue. We need to, I think what we've heard in Norway tells us that we're remaining vigilant to news that might inform how we roll this out going forward. So I think, in summary, I would keep what's happened in Europe in perspective, and just remind us that the system's working. Indeed, if everyone's vaccinated, then that means everyone who dies will have been vaccinated. So if you look at it in that extreme setting, you can see why you're going to get adverse events happening once you've got, or apparently happening, once you've got millions of people vaccinated.
Right. Prof. Cook, on to you. Why is it important for older people to still get vaccinated despite the low numbers here?
So the numbers are low in the community just now, but we can't take that for granted. It's not necessarily going to be the case that we can keep the level of infections at this low level for indefinitely. And so I think as a result of that, it's important to get the vaccine when it becomes available to you. In the long run, we may be vaccinating a million people a month or something like that. But if we have an outbreak all of a sudden, then you're going to end up with a lot of people who are trying to get vaccinated, but we won't be able to manage that. We can only manage 1 million a month, right? That means then that it's important that when your slot comes, it's not worth delaying just over this potential risk. A point that Dale quite often makes is that there's a potential risk with vaccines, but there's a very real known risk with getting COVID. And that far outweighs, especially for the older age groups, any potential risk of the vaccine.
Right. Prof. Fisher, in terms of criteria and health conditions, which older people should not take the vaccine for now?
So as a principle, I would urge all elderly people to get vaccinated. I would urge everybody to get vaccinated, but it's especially the elderly, whatever age you want to call that. Certainly maybe 70 plus, 75 plus especially. This is the group most likely to receive benefit. These have a higher death rate. We know this, and I wouldn't, perhaps on a case-by-case basis, I might give some exemptions. So if you've just had a flu vaccine, for instance, we suggest that you wait a month before having the next vaccine. That's just to separate them a little bit in terms of their immune response. I would think if you have a serious or life-threatening illness, and especially if you're getting treatment for that, and especially if you're heavily immune suppressed maybe in that treatment, then I could see some medical conditions where maybe it's not such a good idea to get the vaccine, largely because it won't be effective probably. But these are exceptional. I really would urge this to be a widespread uptake. And if you think you should be an exception, then have a talk to your doctor and discuss it on a sort of a case-by-case level.
Well, thank you so much, professors, for taking time off to speak with me today. I've been speaking with infectious diseases experts, Professor Dale Fisher from National University Hospital and Associate Professor Alex Cook from the Swee Hock School of Public Health at NUS. A quick look at overseas before we go. US President Donald Trump is ending his term with the lowest approval rating of his presidency. According to Gallup, just 34% of Americans approve of the job he's doing as president. It's the same rating received by Presidents George W. Bush and Jimmy Carter in their final Gallup polls. Historically, Harry Truman was the lowest at 32%. Trump's approval high point came in early 2020 at 49% during the early stages of the coronavirus pandemic, when Americans gave him high marks for his response to it. Amid a resurgence in COVID-19 infections, Hong Kong will impose new measures and expand mandatory testing to buildings that have at least one confirmed case within the past 14 days. Current restrictions such as two-person cap on public gatherings, forced closures of beauty parlors, gyms and bars, as well as a ban on dining in at eateries from 6 p.m. will be extended as well as they expire on Thursday. Meanwhile, a panel of experts said yesterday that they have recommended that the Pfizer-BioNTech vaccine be approved for use. And in sports, the Premier League said that 16 players and staff had tested positive for coronavirus in the latest round of testing. This is a significant drop from the record 40 cases that were reported 2 weeks ago. It also eases fears of another shutdown for the English top flight. And those are our top stories for today. For more news and videos, visit straitstimes.com, and remember to subscribe to our YouTube channel by hitting the red button below. I'm Haryanto Diman. See you tomorrow on The Big Story.